And I would like to invite Dr. Akhtar Ahmed. Dr. Akhtar Ahmed is one of the most senior nuclear medicine physicians of Pakistan. And he is going to talk about a very, I would say, interesting topic from the learning point of view. Let's report it properly, pearls in pitfalls in NM reporting. Dr. Akhtar.
Bismillahirrahmanirrahim. When I got this topic, I was confused what to talk about. So I have reframed it as I understood. Anyway, so this is not technical subject. We are going to discuss something different today. To start with, the outline of my talk will be the elements of nuclear medicine reporting, types of nuclear medicine reporting, pearls and pitfalls of these types of reporting, and what are REDS, the reporting and data systems. I don't have any disclosures. So in 2013, the ACR introduced the Imaging 3 initiative to shepherd the shift from volume-based care to value-based care. And when we talk about value-based care, it's quality, clinical outcome, and the cost. And the mechanism through which nuclear medicine can achieve this paradigm change is improvement to the major work product of the nuclear medicine imaging value chain, which is the nuclear medicine report, which we dish out when we complete the procedure. So most of us learn during our academic career the interpretation of the images, and we think that is all we have to learn. But how to put these interpretations is also very important, and there are certain things we need to learn. Now, in clinical scenario, we know many things which are reported as pitfalls or what we can interpret it positively or negatively. Say, for example, in obstructive nephropathy, the effect of full bladder effect counts, and in myocardial perfusion imaging, the attenuation of different organs counts. And there are so many guidelines which we can go through to learn these things. To start with, what are the elements of nuclear medicine reporting? The foremost is the study identification. Then we mention the clinical history, procedure, finding, comparison, and impression. In the study identification, we have to mention the patient name, and that has to be complete patient name with husband, son of, mother of, because there is always confusion when we call the patient for imaging purpose. We have 2 or 3 patients which have got identical names, and we are going to inject the activity, so we have to be very careful. The other information to uniquely identify the patient, such as gender, date of birth, medical record number, or study code. We are trying to implement CNIC, but unfortunately not all patients have CNIC, so at least these things should be included. Requesting physician and other appropriate healthcare providers, such as the primary care physician. The person who has referred to you is important for us, and we have to mention it. And most of the time, also, we don't mention the full name of that person, and that is not fair to him. So we should mention that person's name, type, date, and the time, if relevant, the study, and study accession number. Now, you know, in most of the PAC system, it's not the medical record number, the study accession number is different. So if you want to access the study, you have to input the study accession number and then complete date and times, because time is important, more important than PET studies. Then we have to mention the indication, which is basically what abnormality we are going to evaluate, and a specific clinical question which referring physician has asked. And so that we know that what we are answering, are we up to his expectations. Then we go for relevant history, which is basically for oncological imaging is very important, the biopsy results, chemotherapy, radiotherapy, and other treatments. The significant relevant medical and surgical history, and also the date of surgery is important, because we have to mention it. Clinical events in the interval between the request and the study, and previous emerging procedures and the results. Then we have to describe the procedure. We have to name the radiopharmaceutical, the dose which we have administered, route of administration, timing of imaging relative to the radiopharmaceutical administration. Any other drugs which we have used, such as intervention, LASIK or anything, we have to mention it. Any other catheter or device we have used, or imaging technique, including alteration in the normal procedure which we do. And then complication or patient reaction. This is again important if we are doing a contrast study. When the patient has experienced it, we should mention in the report so that next time whenever he goes to some other institute, the doctor or physician attending him or her should know these things. Then we put significant positive findings as well as pertinent negative findings should be mentioned. Image quality or other causes of study limitation, such as patient motion, is again need to be mentioned. The reference range may be useful for those when we use quantitative parameters. And the correlation with other imaging studies should be documented in the report, describing the date type of the prior study. If other studies are not available for correlation, this should also be mentioned in the report. And we should also see the individual guidelines and specific for these things. Then in the final impression, a separate impression should be included for all but shortest reports. The impression should address the clinical indication for the scan. Diagnosis, differential diagnosis, and the judgment about the significance of the pertinent findings may be included in the impression. The key structural component for impression should be favored diagnosis, key findings supporting the diagnosis, alternate diagnosis and the reasons for considering them, and also the recommendation for reaching a definite diagnosis or treatment. And finally, the comments, and we should also mention the study limitations. Recommendation for further procedure if necessary, say for example biopsy. Documentation of direct communication of the results, including the name of the physician or physician designate at the time and date of the contact. Sometimes you receive a phone call and they ask about the short report. And it's better to mention that short report in the report so that we are sure that what we have said is communicated safely. The comments may be included in the impression section, especially when brief. So this was the first part. And writing a good report. There are several recommendations specific to most imaging modalities, how to write a good myocardial perfusion imaging report. And you can find this in the literature. But basically, how to write a report. There are three ways to write a report. And first is the free text report, which is the conventional. And most of the nuclear medicine physician, I don't know, at least what we have trained or where we have been trained, we usually use free text paragraphs to describe patient outcome and the result. The next level, which we are adopting to a certain extent, is known as structured layout, in which we present the findings in a standardized, predefined order via template. But again, there is a free text is seen in each segment of the report. And it includes hierarchical or itemized reports. Say, for example, we use head and neck, chest, abdomen, and this type of thing. The level 2 is the structural content, which is basically the future, as we are talking about AI and anything. Use of an IT-based tool to construct the report and insert predefined medical content. The output is supplemented by the reporting physician, and that was we talking where the physician comes into the action. The feature of a structure report can include a drop-down menus, pickup list, gap filling, or decision trees. So these are the 4 types of the structure report. You can have either drop-down menu, you can have pick list, gap filling, or flowchart guided. If just for example, there are some disadvantages and advantages of this type of reporting system. For the unstructured or free text reporting, we usually use non-standard terminology. The verbiage is variable and there is potential ambiguity. Say, for example, if we say suggestive of, we say conclusive or some other thing, that might mean something different for every person who's reading the report. And there is a degrees adherence to international guidelines. Concordance associated with phrases is poor between the nuclear medicine physician and the clinician. And the level of confidence is different from what we intend to do. Mostly we are dependent on the transcriptions, and transcription services are costly. Usually preliminary reports are not promptly available. The dictation and transcription are error prone because what you have dictated may not have been typed as it is. The report signature cause additional delays. There is a need for referring physician or not made, and the text report is not useful for later research or computerization. There is pits and pitfalls associated with structure report also, and to summarize it, the pearls of structure reporting are the reduction in diagnostic error. There is a comprehensiveness of the reporting, adherence to the consensus guidelines, augmentation by interactive multimedia elements, and this also enables us for automatic acquisition of large quantity of structured data, which can be used for secondary use of data in research. Now, this is a format for, say, for example, DEXA reporting, and this is a structure reporting. And you can use this data for further research, and you just have to put few inputs, and you can dish out a report, which could be a structure report. Now, this is a structure report is important in the sense in the future. AI has so far been used in the interpretation of the images, but AI can have a role in implementation for non-interpretive areas of imaging practice likely to precede wide implementation as an interpretive agent. AI algorithm can integrate nuclear medicine report data with evidence-based clinical guidelines and recommendations and improve the efficiency and accuracy of the generated reports. Now, the ACR has adopted a system which is based on the lexicon. Lexicon is basically the terms which are standard, and they have provided so far 9 RAD systems. And these provide standard imaging findings, terminology, report organization, assessment of structure and classification for reporting and data collection in patient imaging. Say, for example, if you go to ACR tires, you can see we can grade it, and by giving out a simple single word, the clinician can understand what stage is and what to do with these things. The same thing can be done in nuclear medicine also. We can have NCAD RAD for nuclear cardiology, and to say, just like in Johns Hopkins, they have introduced PSMA RADs, and they introduced first version in 2018, and the second version was introduced last year. And basically, when they have, what they are doing is that they are giving anatomical location, MITNM staging, which is based on the prostate cancer molecular imaging standard evolution, which is promised, the size of the lesion, the number of the lesion, PSMA SUV max, which is quantitative data, and then PSMA expression on visual assessment, and then the reader confidence through PSMA rates. And there are 5 RAD groups, and in a recent publication from Germany, they analyzed the application of RADs in the clinical practice, and they found that there is an excellent inter-reader and intra-reader agreement for overall scan scores and compartment-based score using PSMA rates. And PSMA rates is a reliable tool for accurately diagnosing and planning treatment for prostate cancer patients and can be used confidently in clinical duties. So we can go for these developing RAD systems and structure reporting system to improve our nuclear medicine approach towards our reporting. There are other standardized classification schemes in reporting oncology PET scan. Say, for example, we are using DEVIL score for lymphoma and multiple myeloma, Hopkins criteria for head and neck tumors and lung tumors, lymphoma response to immunodeficiency criteria, which is LARIC, and then PET response evaluation criteria for immunotherapy, which is PERSIM. And there is a staging with prostate-specific membrane antigen-targeted therapy, which is PROMIS, and also for somatostatin receptor PET in the staging of neuroendocrine, which is basically kerning scoring system. So we have to standardize our system and incorporate all elements which I mentioned in there. We have to adopt the structure reporting system. We should go for development of the rates for all our nuclear medicine imaging system and adherence to the concise guidelines. And also, we should augment our reports by use of artificial intelligence. Thank you.